Today we have an opportunity to learn from Assistant Professor Wipusit Taesombat. He is graduate from the Taesombat Thai Board of Surgery, and then he learning in hepatobiliary surgery and transplantation in the Asan at Seoul, and learn advanced laparoscopic surgery in California. Please welcome Dr. Wipusit.
Thank you. Good morning, all the audience. Also, thank you for the committee for inviting me to talk about this topic. I would say that the bleeding management is very interesting topic, but it's difficult to present, I think, because there are lots of aspects. There are lots of aspects that we concern and will affect a lot how to manage the bleeding in liver resection. So my talk, I will focus on my practice and show you how I think when I dealing with the bleeding. As you all know, the bleeding is one of the very big problem when we do liver resection, especially for rapid liver resection. Particularly if massive bleeding will lead to complication and open conversions. This right hepatectomy for liver mets. And if you see the middle hepatic vein, in this case is very thin and collapsed, indicating you have a very good CVP and lower hepatic vein pressure. I think if you deal with bleeding, anyone who can do the laparoscopic surgery, I think is easy to control. That I think this I would give the credit to our anesthesiologists. So if you want to do the rapid liver resection, you have to have a very good friend with your anesthesiologist who have understanding the how to manage anesthesiologic technique during liver resection. Nowadays, we focus on the hepatic vein pressure because most the common site of the bleeding during liver transaction is coming from the hepatic vein. So we focus on lowering the hepatic vein pressure rather than the central venous pressure. Actually, most of the time, the CVP will correlate with the hepatic vein pressure, but in some very selected case, you may see that you already have the lower CVP, but still bleeding from the hepatic vein, because there's still many factors that affect your CVP, like right heart function, intrathoracic pressure, intra-abdominal pressure, or anatomy of the vein, or anesthesiologic technique. I will show some example. This is a very interesting study that shows the anatomy of the IVC from Japan. They study the gap between the IVC and right atrium that divide into groups. For the large gap, that means the junction from the RA to the IVC to the lowest part of the IVC in hepatic segment. If the patient has the very large gap compared to the small gap, can you guess which one will cause more bleeding? This last one. They show that the middle hepatic vein pressure is higher and resulting in more bleeding during dealing with the liver resection. That is anatomical, so we cannot change. But sometimes we can adjust the patient position or try many ways to lower the pressure intra-abdominally. Another three factors that I usually concern when I'm doing rapid liver resection is the first one is exposure. It's like open surgery. If you got a good exposure, it's easy to control anything, right? for the laparoscopic surgery is meaning for the port position, patient position, and also the visualize system. You will need to put the very good system. And the second one is the transaction direction is very important, that like Professor Itano showed us, if you go into the intersegmental plane correctly, it should be less or no bleeding, particularly when you do the anatomical resection. The last one is the laparoscopic skill. Definitely you need to improve your skill and instrument as well. But I think the instrument is any instrument you can use. You just need to familiar with your instrument, I think. So what about the best practice? I don't think up to date there's no standard practice, and I'm not sure about what is the best practice. So my talk today, I will show you my practice and my thinking when I dealing with the breathing. The principle is the same, I think, but some minor technique may be changed over time. Let's start with the first case. This is about 9 years when I doing learning, start to do the wrap reverse resection. The tumor in the caudate in spical lobe, I just do the wedge resection. And during the parenchymal transection, some bleeding. So I use the bipolar to grab it. And it seemed like a less bleeding, so I burn it. And you see what happened. Oh, a lot of bleeding. So I try to grab it again. It's still more bleeding. I think this is time maybe need to call for help and maybe prepare to open, but need to do some temporary control bleeding. So I grab it, the IVC wall, and this is my last attempt. Do it laparoscopically and use the bulldog. Fortunately, it's stopped. So I complete the parenchymal transection and suture it. What I learned from this case, I think first you have to determine what the source of bleeding. Definitely you cannot burn the hole in the short hepatic vein on the surface of the IVC. Please not. I think this is my thinking process. I will thinking first what the vessel I dealing with, and then you can choose your approach to stop it. The second case is the recurrent HCC after open surgery 5 years ago. So I attempt to do the lap resection, and it takes me more than 2 hours to lysis the adhesion from previous surgery, and then proceed just small wedge resection. And I usually use the ultrasonic device to do the parenchymal transection, and you see this, the bleeding come from, I'm not sure, but the blood is quite red. It should be come from the pedicle. So I try to stop it with the bipolar. After it's temporary control, I try to identify it because I think it's bleeding from the pedicle. So usually I try to grip it to secure the bleeding and also secure the bile duct. And I proceed more, still bleeding. And again, I try to burn it with the bipolar because I think it came from the pedicles. So it's not stop bleeding, so I pack it. And then take your time and go around. Change to another side. so it's still breathing. Still breathing. The problem is, I think, is this is breathing, still breathing from the pedicle. That means your pingo is not that completely cramped, the inflow. So I need more time to dissect the inflow control. And you see this after I completely cram the inflow, it's much better. And then you go back to the breathing point. It should be easier because the pingo was applied completely. And again, I think this is maybe breathing from the pedicle, so I try to creep it. Because if you using the vessel sealing device, sometimes it's caused by leak after the operation. So proper inflow control is mandatory. So the type of inflow control is depend on your procedure you plan to do. And again, if I think the breathing from the pedicle, I try to temporarily control it and usually use the mechanical clip to secure it. The third case, this is I assist my young colleague to do the first case of the right hepatectomy several years ago. And this case have the really large V8 ending into the middle hepatic vein. During the dissect, try to encircle the vein is, I think it's tear some the posterior branch running to the V8. So we can compress it and clean the camera and clear your surgical view because we can temporarily control with the compression already. So, and thinking how I can stop this, so I changed the pan, the direction of transection to do from the dorsal first to try to slowly go to the breathing point. And this is a liver capsule that just anterior to the IVC and that the breathing point. So now you can see it clearly. You can like a focus compression. And then do try to encircle it. But still cannot from the right hand. So I changed to my left hand. It's a better angle to control the breathing. So now you can encircle it completely, so it's easily to cut it for now. Final picture. I think nowadays we have the very good pre-operative image, so we know before the operation what vessel we have to deal with. So so the understanding anatomy is very important. But compared to open surgery, the anatomy or structure is the same, but from just different view when you do it laparoscopically. So I always told my fellow you have to get familiar with the laparoscopic view because it's the same anatomy but from different angle. So you need to understand the anatomy. So if you understand it very well, you can guess it what you deal with. This is the last case. Just talk about the raw surface. management. I think though there are lots of hemostatic agent in the market, but I think no, it's still the same. I usually just use the Surgicel to cover the surface for some times. And most of my breeding on the surface, I use the bipolar to burn it. In this case, I'm not sure I miss some small pedicle or small bar duct or nose. I sometimes use the fibrin glue. Hopefully, it can help. It can help to prevent the bile leak after surgery. And I usually put some kind of hemostatic agent on the major hepatic vein surface. This is the middle hepatic vein. For the open conversion, I think it's still the viable option. But before you open, you still need to have some kind of temporary control of the breathing. You cannot let it breathe and then you open. I think you cannot go in time. So you still need some kind of packing or partial cramping of the breathing point. So you, because you take time when even you do the open to go into the breathing point. I have no conclusion, but I think that's take home message. I still encourage all of you to do the laparoscopic surgery, but need to keep practicing and learning from the expert or your mentor is mandatory. I think it can shortcut your training, and it's very important is learn from yourself. It's easy to review the recorded video of your own operation, and you will see, oh, why I do this, why I don't do this. It can fasten your technique adaptation and shorten your learning curve, and then you can create your own approach when you dealing with the breathing in reverse surgery.